All right, clipboard's out, pen's ready. Let's set the scene properly. We are walking down the corridor of a teaching hospital.
Okay.
It's early morning, the lights are that specific kind of clinical fluorescent bright, and the air has that distinct mix of floor wax and rubbing alcohol.
I can smell it already.
Right. So I'm stepping into the shoes of the resident today, the learner, the one managing the list. And you are the attending neurologist. We're about to round on a new admission.
Rounding is the right word, but let's be really specific about the headspace here. When you walk toward that room, you aren't just a data collector, not at all. You are an investigator.
An investigator.
The neurological exam is the most logic-driven, the most anatomically precise tool in all of medicine. If you do it right, you can pinpoint a lesion to within a few millimeters of brain tissue before you ever even think about ordering the MRI.
And that is the goal for this deep dive. We're breaking down the art of the neuro exam. We aren't just going to, rattle off a checklist of squeeze my hands, kick my hands.
No, absolutely not.
We're going to deconstruct the why and the how of assessing the body's absolute control center. We're talking about the brain, the brainstem, the spinal cord, and all the wiring that makes us human.
It is the wiring of the human experience. That's a great way to put it. Movement, sensation, thought, speech, survival reflexes, it's all there. And my role here is to ensure we don't just stay on the surface.
Okay.
Clinical accuracy is paramount. You can hurt a patient just as easily by missing a subtle sign as you can by prescribing the wrong drug. So, resident, let's begin. We are at the door. We haven't entered yet. What is your first move?
My first move is a general survey, the look. According to the source material, the exam starts the absolute second. I lay eyes on the patient even if I haven't introduced myself yet. I'm observing their dress, their grooming, their hygiene.
And why? Why does that matter? It sounds almost judgmental, but it's deeply clinical. What is a messy appearance telling you, potentially, about their neurology?
It speaks to their executive function. I mean, if we have a patient who is historically meticulous, say a lawyer or a teacher, someone who values their appearance, and they present looking disheveled, unwashed, maybe they're wearing a heavy coat in July.
Right.
That's not a fashion choice. That's a potential frontal lobe issue. They've lost the ability to plan, to care for themselves, to even recognize social norms.
Exactly. You are assessing the prefrontal cortex immediately. But look deeper. Look at the patient lying there in the bed. Observe their posture.
Okay, so I'm checking if they're upright, if they are slumping over. Leaning to one side is a big red flag for neglect, right? Where the brain literally ignores half of the body or half of space.
Correct. And that's usually a parietal lobe issue. But I want to talk about the really ominous stuff, the postures that make you want to sprint to the nurse's station. The prompt mentioned decerebrate versus decorticate posturing. Let's distinguish these because mixing them up is a classic rookie mistake, and the anatomical implications are completely different.
Okay, right. These are signs of severe brain damage, usually involving the brainstem or that connection between the brain and the spinal cord. Let's start with decorticate.
Decorticate. The clue is right there in the name, cortex. The problem is usually deep hemispheric or right at the level of the internal capsule, but the brainstem itself is, for the most part, intact. What does it look like?
The patient's arms are flexed inward, pulled in tight toward the core. The hands are clenched into fists right up against the chest, and the legs are extended. It almost looks like a mummy position.
Flexion, that's the key word. This happens because the red nucleus in the midbrain, which drives flexion, is still working, but it's lost its inhibition from the cortex above. It's basically an unchecked flexor response. Now, compare that to decerebrate.
This one is worse, isn't it?
Right.
Statistically speaking.
Much worse.
The arms aren't curled in. They are extended straight down by the sides, completely stiff. The wrists are rotated, outpronated, and the legs are also stiffly extended.
This indicates the damage is lower down. It's below the red nucleus. The brainstem is taking a massive hit, often at the pontine level. If you walk past a room and you see a patient spontaneously posturing into extension like that, you are in a code situation.
Wow.
That is not a finish your coffee and then check on them moment. That is an airway and neurosurgery now moment.
It's just terrifying that body position alone can map the lesion level that precisely. Okay, now, moving to something that seems almost mundane but is actually life or death in our context. Body type and BMI. Our notes highlight this specifically for stroke protocols.
Yes, and this is such a practical safety point. In the ER, things are chaotic. But if this patient is having an ischemic stroke, a clot blocking a vessel, we might need to use thrombolytics, TPA or TNK.
The so-called clot-busting drugs.
Exactly. And those drugs are strictly, and I mean strictly weight-based, dosed by the kilogram.
So if I just eyeball the patient and I underestimate their weight,
You underdose the drug, the clot doesn't break up, the brain continues to die.
and if I overestimate,
You overdose. You strip their clotting factors so aggressively that they can bleed into their brain. You turn an ischemic stroke into a fatal hemorrhage. So that general survey where you estimate BMI isn't just paperwork. It's the first step in calculating a potentially lethal dose. Accuracy matters.
that puts it into perspective. Okay, so let's assume we're seeing signs of immediate distress. We suspect a stroke. We need to deploy the FAST scale. This is the rapid triage tool.
FAST. Walk me through the clinical nuance. Don't just give me the letters.
Okay, F is for face. We're looking for asymmetry, a facial droop.
Specifically, it's usually the lower face. We'll get to why when we talk cranial nerves, but you ask them to give you a big smile. If the nasolabial fold, that line from the nose to the corner of the mouth, is flat on one side, that's a positive hit.
Got it. A is for arm. We ask them to hold both arms out, palms up, with their eyes closed. We're looking for drift.
Pronator drift. It's a very subtle but very important sign of weakness. The arm doesn't just fall. The palm turns inward, it pronates, and then it drops. That's a classic pyramidal tract sign.
S is for speech, slurred speech, or maybe the inability to find the right words.
Dysarthria or aphasia.
Yep.
Two very different things neurologically, but both are positive for the FAST screen.
And T is for time. Time is brain. But here's a question. When we document time, are we documenting the time they got to the hospital?
No, absolutely not. And this is a critical distinction that can get missed. We need the last known well time. If a patient woke up with symptoms at 7 a.m., the time isn't 7 a.m.
Oh, bro.
The time is when they went to sleep the night before, because the stroke could have happened at any point in between. That clock dictates everything. If you are outside the therapeutic window, usually 3 to 4.5 hours for IV TPA, our options change drastically.
So aside from FAST, are there any other red flags in this initial survey before we even start the formal testing?
Always look for the posterior circulation signs. FAST is great for the big hemispheric strokes, the ones affecting the carotid distribution. But if the stroke is in the back of the brain, the cerebellum or the brainstem, they might not have arm weakness. They might have vertigo, severe dizziness.
Like the room is spinning.
Exactly. Or diplopia double vision. Or a sudden thunderclap headache. Or, and this is a big one, an altered level of consciousness, LOC. If the patient is confused, agitated, or just abnormally sleepy, that is a neurological deficit until proven otherwise.
That segues us perfectly to segment 2. So we're at the bedside now. We need to establish mental status, history, and speech. This is where we actually start talking to the patient.
You start with LOC, level of consciousness. In the chart, we always see that shorthand, ANO by 4, alert and oriented times 4.
Person, place, time, and situation. But I feel like a lot of people just autopilot this. You know, what's your name? Where are you?
They absolutely do autopilot, and they miss things like delirium. You have to ask specific probing questions. For time, don't just accept it's Tuesday. Ask for the year. Ask for the month.
And asking who is the president is a classic one.
It is, because it tests both semantic memory and general awareness of the world. But you have to be careful. That can sometimes be a bit political. Sometimes I'll ask, what holiday is coming up next? It forces them to orient themselves to the season.
The distinction we are trying to make here is between lethargic and disoriented.
Right. A lethargic patient is sleepy. Maybe they have sleep apnea. Maybe they took a sedative. But if you can wake them up, they know who they are and where they are. A disoriented patient can be wide awake, staring right at you, but they think they're on a cruise ship in 1994. That's a content of consciousness problem, not an arousal problem.
And what about the quality of the interaction, behavior, and conversation? We're looking for nonverbal cues here, too.
Absolutely. Is the patient agitated? Are they picking at the bed sheets? That carphology, that sort of imaginary picking at objects, can be a sign of delirium or a metabolic encephalopathy.
And then the verbal cues. Is the conversation logical? This brings us to aphasia, the breakdown of language itself.
And this is one of the most devastating neurological deficits there is. We absolutely need to be able to distinguish between the two main types, expressive and receptive.
Okay, let's start with expressive aphasia, also known as Broca's aphasia.
Named after Paul Broca and the area of the posterior frontal lobe. In this scenario, the patient's comprehension is intact. They understand every single word you're saying. They know exactly what they want to say, but the motor planning to get the words out is broken.
That must be incredibly frustrating for them.
It is heartbreaking. They are non-fluent. They might just be able to say, book, book, when they really want to ask for a magazine. They are often acutely aware of their deficit, which leads to a lot of depression and anger.
Okay, now contrast that with receptive aphasia, Wernicke's aphasia.
This is a temporal lobe issue.
Yeah.
Here, the patient is fluent. They can produce words effortlessly. The problem is the words have no meaning.
The classic word salad.
Exactly. I went to the store to fly the purple breeze. The cadence is normal. The grammar is often surprisingly normal, but the content is complete nonsense. And cruelly, these patients often don't realize they aren't making sense. They think they are having a perfectly normal conversation, and they get confused and frustrated about why you don't understand them.
So while I'm taking the history, I'm testing for this. I'm listening to their articulation, their prosody, the whole time.
You are always testing. History taking is the neuro exam. The two are inseparable.
Let's talk about the history itself then. Why does that chart review matter so much for a neuro exam?
Because the brain is the target organ for almost every other systemic failure in the body.
Okay, so we look for hypertension and diabetes. Obviously, those destroy blood vessels over time. But why is atrial fibrillation AFib such a massive red flag?
It's all about the mechanism of the clot. In AFib, the top chambers of the heart, the atria, are just quivering. They're not squeezing effectively. Blood creates these little eddies and pools, usually in a place called the left atrial appendage.
And stagnant blood clots.
Stagnant blood clots. Eventually, the heart kicks that clot out. And where does it go? The first major exit ramp off the aorta goes straight to the brain, the carotid arteries.
So an irregular heartbeat is basically a loading gun pointed at the brain?
Precisely. If I see AFib on a patient's chart and they come in confused, I am assuming an embolic stroke until proven otherwise. Period.
We also look at social history, tobacco, alcohol, and recreational drugs.
And the route of administration matters immensely. IV drug use, for example, puts you at high risk for endocarditis bacteria growing on the heart valves. Those clumps of bacteria can break off and cause septic emboli in the brain abscesses. It's a totally different pathology than a smoker who has atherosclerotic plaque buildup.
Okay, we've surveyed, we've chatted, we've checked the history. Now we get to the technical core of it. The cranial nerves, all 12 of them.
Ah, the anatomy of the brainstem. This is really where we separate the amateurs from the pros.
We're going to group them. Segment 3 will be the senses in the eyes. So CNI through 6. Let's start at the top with CNI, olfactory.
The smell nerve. Often skipped in a busy ER, but it's vital. The olfactory nerve is unique. It has neurons that are directly exposed to the outside world, right there in the nasal mucosa.
So we test it by occluding one nostril and asking them to identify a common smell, like coffee or mint.
But why do we care? What's the clinical significance?
Well, aside from just quality of life, loss of smell anosmia is a very early biomarker for neurodegenerative disease.
It is often the very first sign of Parkinson's or Alzheimer's disease, appearing years, sometimes decades, before the tremors or the memory loss. The pathology actually starts in the olfactory bulb. Also, a frontal lobe tumor, a meningioma, can compress the olfactory nerve and present with loss of smell.
Good to know. Okay, moving to CN2, optic. This is all about vision.
Visual acuity, to be precise. And we use the Snellen chart, the big E.
Standard protocol. The patient stands 20 feet away. You have them cover one eye, read the smallest line they can, repeat on the other side, then with both eyes.
But don't just check acuity. You have to check their visual fields. Confrontation. You have them look at your nose and tell you when they can see your wiggly fingers coming in from their periphery.
And this is to catch things like a hemianopsia, where they're blind on the same side, say the left side, in both eyes.
Which is a classic sign of a stroke in the optic radiation or the occipital lobe. They might have perfect 20/20 vision straight ahead, but be totally blind to their entire left side. They'll run into door frames. They won't see you coming from that side.
Now for the eye team. This is the heavy lifting. Cranial nerves, the 3rd, 4, and 6, oculomotor, trochlear, and abducens.
They control the extraocular muscles. We test them all together because they have to work together in a coordinated dance.
Let's start with just the pupils. That's CNN3, the oculomotor nerve, right?
Mostly, yes. The protocol is per RLA, pupils equal, round, reactive to light, and accommodation.
So we shine the pen light in from the side. We expect to see both pupils constrict.
Right. But here is the deep dive. The oculomotor nerve isn't just one wire. It's a bundle of fibers. The fibers that control the pupil, the parasympathetic fibers, they run on the very outside of the nerve bundle. The fibers that move the eye muscles are deep inside.
Okay, why does that specific anatomy matter so much?
Compression. If you have a brain bleed or a tumor that is pushing on the nerve, it's going to crush the outside fibers first. So the pupil stops constricting, it blows, it becomes dilated and fixed. A blown pupil is a classic sign of physical compression, often from a brain herniation.
As opposed to something like diabetic neuropathy, which would be an issue with blood supply inside the nerve.
Exactly. Diabetes damages the tiny microvessels deep inside the nerve. So the eye muscles can get paralyzed, but the pupil is often spared because those outer fibers are getting their blood supply from somewhere else and aren't being compressed. We call that a pupil-sparing CN the third palsy. That distinction tells you if you need to call a neurosurgeon or an endocrinologist. It's huge.
That is fascinating. So for the movement part of the test, we use the 6 cardinal fields of days, the wagon wheel method.
Or the H pattern. You hold your finger up, you tell the patient, follow my finger with your eyes only, don't move your head, and you move smoothly out to the extremes.
And we are checking all 3 nerves at once, 3, 4, and 6.
Let's break it down. CNI eye is the abducens. It adducts the eye, it moves it outward, away from the nose. If you ask the patient to look to their left and their left eye gets stuck in the middle and can't go out, the abducens is out.
Then CNIV is the trochlear. It controls just one muscle, the superior oblique.
Which is the down and in muscle. It's the muscle that helps you walk downstairs or read a book in your lap. Patients with a CNIV palsy will often come in with their head tilted to the side to try and compensate for the double vision they get when they look down.
And CN third does everything else. Up, down, in.
All the other movements. So if CNV third is completely knocked out, the eye is down and out. It gets pulled down and to the side by the remaining functional muscles. And the eyelid droops. That's called ptosis.
Okay, the eyes are done. That was a lot. Let's move down the brainstem. Segment 4, the face, ears, and throat. So CN 7 through 12.
Before we go on, let's clear up the common confusion between CNV and CNG, trigeminal versus facial.
Okay. CNV, the trigeminal, meaning 3 branches.
The ophthalmic, maxillary, and mandibular branches. This is the primary sensory nerve of the face.
So we test sensation, light touch. I'll say, close your eyes, tell me when you feel the cotton swab, and I'll touch their forehead, their cheek, their jaw, comparing sides.
Good. It also has a motor component, the muscles of mastication. Chewing. So you'll have them clench their teeth and you feel the masseter's muscle bulge.
Now contrast that with CN7, the facial nerve.
This is the motor nerve of facial expression. It's what lets you show emotion.
So we ask them to make faces. Smile, frown, puff out your cheeks, raise your eyebrows.
And here is probably the most important clinical pearl of the entire neuro exam, certainly when it comes to distinguishing a stroke from Bell's palsy.
It's the forehead, right? It has to do with the forehead.
It's all about the forehead. The upper face, the muscles that wrinkle the forehead, receives input from both sides of the brain, bilateral innervation. But the lower face only gets input from the opposite side of the brain.
So if a patient has a stroke in, say, their left hemisphere,
the backup connection from the healthy right hemisphere keeps the forehead moving. They can still raise both of their eyebrows, but the lower right side of their face droops.
But if they have Bell's palsy, which is just an inflammation of the nerve itself after it leaves the brain.
The whole wire is cut, the signal is gone, the entire half of the face is paralyzed. They can't smile, and they cannot raise the eyebrow or close their eye tightly on that side. So if the forehead moves, you should be worried about a stroke. If the forehead is frozen, it's more likely Bell's palsy.
Wow, that is so counterintuitive. Sparing is scary. Sparing means stroke.
The mnemonic we use is spare the forehead, spoil the brain.
That's a good one.
Oh.
Okay, moving on. CN8, acoustic or vestibulocochlear.
Hearing and balance. 2 functions in one nerve.
For hearing, we do the whisper test. I'll stand behind them so they can't lip read, have them occlude one ear, and I'll whisper something like baseball or 99 or orange.
Good. And if they fail that, you then need to differentiate a conductive hearing loss, like earwax or fluid, from a sensorineural loss, which is nerve damage. That's where the Weber and Rinn tuning fork tests come in, but the whisper is the initial screen.
Got it. Now, CNIX, glossopharyngeal, and CNX, vagus, the throat team.
Yes, these are your airway protectors. They are critical. CNIX is mostly sensation in the back of the throat. CNX is mostly motor for the palate and the larynx.
And the test is the gag reflex.
You gently touch the back of the throat with a tongue depressor. The palate should rise symmetrically and instantly. It's unpleasant, but if a patient has had a stroke, you must know if they can protect their airway before you even think about giving them a sip of water.
And for the vagus nerve specifically, we ask them to say, ah.
Yes, and we look at the uvula, the little thing hanging in the back. It should rise straight up in the midline. If CNX is damaged on the left, The muscles on the right will be unopposed, and they'll pull the uvula over to the right, so the uvula points away from the site of the lesion.
Okay, almost there. CNX of I, the spinal accessory.
This one's a pure motor nerve. It does the trapezius and the sternocleidomastoid muscles.
So shrug your shoulders, I'll put my hands on them and push down while they push up.
Exactly. And turn your head against my hand to test the other muscle. Simple.
Finally, CN12, hypoglossal, the tongue.
You ask them to stick their tongue straight out.
And if it deviates to one side,
Remember, the tongue is a muscle. If the left side of the tongue is paralyzed and atrophied, the strong muscles on the right side will push the tongue out, and it will curve toward the weak side. So the tongue points toward the side of the lesion.
the tongue licks the lesion.
Yeah, that's the mnemonic,
Yeah.
exactly.
Phew. Okay, that's the entire brainstem. We've covered all the cranial nerves. Now let's check the rest of the body. Segment 5, motor function and cerebellar testing.
The patient is still in bed for now. Let's check their strength.
We grade strength on a scale
Right.
from 0 to 5.
Yes. 5 is normal power. 0 is no movement at all. 3 is important. It means they can move against gravity, but not against any resistance. And you have to check bilaterally and compare.
So upper extremities. The grip test is common. Squeeze my fingers as hard as you can.
A quick tip. Cross your hands so your right hand holds their right hand and their left holds your left. And only offer 2 fingers, not your whole hand, to avoid getting your hand crushed if they have a reflex grasp. You're looking for asymmetry.
Lower extremities. The gas pedals test. Dorsiflexion and plantar flexion.
Push down against my hands like you're pressing a gas pedal, then pull your feet up toward the ceiling against my hands. We're always on the hunt for subtle weakness on one side.
Okay, now let's talk cerebellum. The little brain tucked in the back.
The coordinator. The cerebellum doesn't initiate movement. It smooths it out. It's the difference between a jerky robot moving and a fluid dancer moving.
So to test it, we need to ask for complex, coordinated movements, like the finger-to-nose test.
Exactly. You have the patient touch their own nose, then your finger, then their nose again. And you move your finger around to different spots. You're looking for dysmetria, where they overshoot or undershoot the target. Or an intention tremor, an escalating shaking that gets worse as they get closer to the target.
And then gait. We have to get the patient up, if it's safe to do so.
First, just watch them walk naturally. Is their stance wide-based? Do they shuffle their feet? Then you apply the stress test, tandem gait.
Heel to toe, the sobriety test, the tightrope walk.
This forces the cerebellum to work overtime to maintain balance. If they stumble or consistently fall to one side, that is ataxia.
And finally, the Romberg test. This is the one I see done wrong all the time. People think it's a cerebellar test.
It is not a primary cerebellar test. It is a test of proprioception, the function of the dorsal columns of the spinal cord.
Let's break it down properly then. Step 1.
The patient stands up, feet together, heels touching, arms at their sides, and their eyes are open.
So if they start falling over at this stage,
That is cerebellar ataxia. Their brain can't coordinate their muscles to maintain posture even with all the visual information coming in. The test is over. They have a cerebellar problem.
okay, step 2. They are stable with their eyes open. Now you say, close your eyes.
Now we have removed their visual input. Look, balance relies on 3 systems working together. Vision, the vestibular system in the inner ear, and proprioception, which is your body's sense of its position in space. You can usually balance with any 2 out of the 3.
So when we tell them to close their eyes, we've taken away vision. Now they're relying on just the vestibular and proprioception systems.
Exactly. And if they start swaying wildly or have to step to catch their balance only when their eyes are closed, that is a positive Romberg sign. It means their proprioception is broken. Their feet aren't telling their brain where they are in space. Without their eyes to compensate, they go down.
So, to be perfectly clear, a fall with eyes open equals a cerebellum problem. A fall only when eyes are closed equals a proprioception problem or sensory ataxia.
That is the crucial distinction.
Okay, segment 6. Safety, education, and documentation. We've just gathered a mountain of data.
Now we have to act on it. If you found a positive Romberg sign, that patient is a massive fall risk.
So that leads directly to bedside safety.
Immediately, the call bell has to be within reach. The bed alarm is turned on. You have to explain to the patient, your legs aren't telling your brain where you are standing. You must not get up without help. You have to educate them and their family.
And documentation. Neuro exams and charts are often so lazy. Just a checkbox that says neuro intact.
That is defensible in court, and it's completely useless for the next doctor or nurse who sees the patient. You need specificity. CN2 through 12 intact, Strength is 55 bilaterally. Romberg is negative. Gait is steady.
Or right-sided facial droop noted, sparing the forehead. 45 strength in the left arm with pronator drift.
Now that tells me everything. That tells me right hemisphere stroke. The documentation should tell the story of where the lesion is.
Let's synthesize all of this. We've gone from top to bottom. General survey, mental status, which is the cortex, cranial nerves, which is the brainstem, motor and sensory, which are the spinal tracts, and the cerebellum.
It is a complete systems check.
Yeah.
And you have to remember, the brain is connected to everything. A neuro finding might be the very first sign of a cardiac issue, a metabolic issue like liver failure, or a brewing infection.
So the neuro exam is really the alarm system for the whole body.
It is. The brain is the most sensitive organ to changes in oxygen and glucose. It complains first, and it complains loudly.
So a final thought for our listeners, for the students out there. We've covered a lot of dense anatomy. It can feel really academic.
It can, but I want you to realize this. When you look into a patient's eyes with an ophthalmoscope, you are looking at the optic nerve head. That is the only place in the entire human body where you can see the central nervous system naked without cutting through skin. You are looking directly at the brain. Treat the entire exam with that level of reverence.
And practice. Practice the smooth pursuit eye movements. Practice the whisper test on your family. Do it until you don't have to think about the steps anymore, so you can just focus on what you're finding.
Well said. Just keep your eyes open.
Thanks for rounding with us today. We'll see you on the next deep dive.